Welcome to Season 5 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former health commissioner here in Baltimore, Maryland. Our goal with this podcast is to bring scientific evidence and experience to shed light on critical health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith-Rogers, producer of Public Health on Call. Today, Stephanie Desmond talks again to Dr. Dori Segev, a prolific Johns Hopkins researcher and transplant surgeon, about what we've learned in terms of immunocompromised people during the pandemic and whether the vaccines actually protect them from COVID-19 or if there's more we need to do. Let's listen.
Dori Segev, thanks so much for joining me.
Yeah, great to talk to you again.
Today, I'd like to talk about immunocompromised patients and vaccination. I know that you have been studying them throughout the pandemic, and what you found is that for many immunocompromised patients, the regular 2-dose regimen didn't work, and in many cases, the 3-dose regimen didn't work. So I'm wondering if you could sort of tell me where we are right now.
Yeah, so there are somewhere on the order of about 5 to 7 million immunocompromised people living in the United States who are all kind of struggling and have been struggling for a year with how do we achieve vaccine-induced immunity? How do we know if we have it? How many shots do we need? Which platform do we need? When is it time for the next shot? When is the FDA and CDC going to finally authorize something that they've been doing in France and in Israel for months? Are we going to get sick? If we get sick, are we going to be hospitalized from it, et cetera, et cetera? When the vaccines came out, nobody really knew how immunocompromised people would respond to the vaccines. They were excluded from the big clinical randomized trials. And so very early, we started to measure antibody levels in people who are immunocompromised after 1 dose, after 2 doses. And it was very, very clear early on that the more immunocompromised you were, the lower of an immune response you had to the vaccine, to the point where 2 shots for many, many people who were immunocompromised was grossly inadequate. There was a good response to a 3rd shot, but even then, so for example, I take care of transplant patients, and transplant patients take immunosuppression to prevent their organs from rejecting, but that suppresses their immune system to respond to vaccines as well. And in transplant patients, even with 3 shots in the currently recommended regimen, I would say that probably about half of transplant patients don't reach a level of antibody that correlates with the kind of neutralization that would give you clinical protection. So probably 75% of them have some detectable antibody, but we've been doing studies recently where we look to correlate the measured antibody level with neutralization. And then there have been other studies correlating neutralization with clinical protection. And based sort of putting all of that together, we would guess that about half of transplant patients don't have enough antibodies to generate enough neutralization for protection, even after 3 doses. And obviously, that's very frustrating.
So they might as well be unvaccinated as far as how protected they are.
Well, so it's likely that there's some protection, and the protection that we see is likely with regards to the severity of their disease, right? So if somebody has 3 shots and they have some detectable antibody and it's not high enough that I would say you're really protected, but they probably have something going on. And the fact that people with no antibody after 2 shots do sometimes demonstrate a lot of antibody after 3 shows us that each dose sort of primes the immune system. We're measuring antibodies and neutralizing antibodies, but there's also memory B cells and T cell repertoire. And there's a lot of stuff happening that we don't really have good ways of measuring or quantifying or correlating with protection. So I would say for certain, it's absolutely critical for anybody who's immunocompromised to get vaccinated. And even if they don't have a lot of detectable antibody, they likely have some amount of protection. But they're still at risk of acquiring the disease at a higher rate than people who are immunocompetent. And they might still get a more severe infection than people who are immunocompetent, although maybe not as severe as had they not been vaccinated at all. Right? So there are these sort of two dimensions to protection. One is, can we prevent you from even getting COVID at all? And two is, if you should get it, can we make sure that at least the disease severity is minimized?
So how can we protect those who are immunocompromised?
Right. So we're doing two things. One is we're working on the vaccine side of things. We got NIH funding to run a clinical trial of people who thus far have failed to reach a reasonable antibody level with whatever vaccine regimen they've gotten. And then we give them another dose, but we randomize them to either just getting that dose alone or getting that dose plus reduction of their immunosuppression. So is it safe to reduce somebody's immunosuppression at the time of a vaccine booster, and is it effective? So we're running a randomized trial. It's a national trial. There are a number of centers currently enrolling patients. And so we're trying to better figure out the stuff on the vaccine side so that ideally anyone who could get vaccine immunity should take that road as the primary road, just because it's so broad-based with, antibodies, memory, B cells, T cells, those kind of things. On the other side is passive immunity. So like giving somebody monoclonal antibodies that were manufactured, they get the antibodies, so they get the antibody-mediated protection. They don't get the rest of the T cell immunity and things like that, but they get so much neutralizing capability of these monoclonal antibodies that does give them some protection. The question is, how durable is that, et cetera? As we know, recently, a lot of studies have been coming out looking at the available monoclonal antibodies and their activity against Omicron. Why is it that some monoclonals don't work well against Omicron, but other vaccine-induced immunity does work reasonably well against Omicron? Again, it's sort of that broad base of immunity that you get from active immunity versus passive immunity. But we're pursuing sort of both roads to try to optimize the immune protection of people who are immunocompromised.
So if I were, say, immunocompromised and I'd had 3 shots, what would you recommend I do? I probably walk around not knowing if I can really, I wonder if I can even leave the house, right?
Right. So one of the big issues is, thus far, much to my disappointment, FDA, CDC, and even a lot of the professional societies have recommended against antibody testing. Now, months ago, so I would say the word historically, which, in COVID time is like 3 weeks ago, historically, the antibody testing platforms were not great. And we didn't have evidence correlating antibody levels. So like you go to a commercial lab, you get your semi-quantitative antibody test done. What does that really mean? We now know from large studies that at least in people who are immunocompetent, the higher your antibody level is, correlates with actual clinical protection, like directly correlates with that. So more antibodies, more clinical protection. We assume that also is going to generalize to immunocompromised people, with the exception that we can't measure the T cell response in immunocompromised people. And in those with normal immune systems, T cell responses, B cell responses, antibody responses all kind of work in synchrony. And that synchrony might be broken in, for example, a transplant patient who is also on T cell inhibitors, for example, right? So, however, we can get antibody tested and get some information. So, for example, if somebody is immunocompromised and they've had 3 doses and they don't know if they're protected or not, and they go and they get their antibody levels done and they're low, I would say in all likelihood, they are really not protected and they need to be super, super, super careful. If they check their antibodies and their antibodies are very high, there still might be less protection than in somebody with a normal immune system because their T cell response might be suboptimal. But at least they have a sense of when they make risk-benefit decisions about their lives, if they have to go to work, if they have to interact with people, at least they have a sense of where their protection might be. I think it's certainly much more valuable. When we think about a test, we think about like, how valuable is a negative result? How valuable is a positive result? A negative result in an antibody test in somebody who's immunocompromised is very valuable because it tells them, unless something really weird is happening, we really don't think that they have good protection. A positive result is less helpful because I can't guarantee somebody that they have protection if they're off the scale. But, if it's negative, I can pretty much guarantee them that they don't have protection.
How easy is it for someone to get a fourth dose? I would imagine it might be complicated.
So another frustration of mine these days is this sort of one size fits all FDA CDC recommendations that are coming out, right? They have for everyone, and then they have for the immunocompromised, but they're not data driven. They're not antibody level driven. They're not individualized. They don't give people's doctors the ability to individualize their care. So for example, if one of my patients got 3 doses and they ended up with a relatively low but still positive antibody, I would want to give them a 4th dose to boost them up to be much higher. But I can't do that today because they are limited. The only 4th dose that people can get is if they had 3 doses 6 months ago. Now they can get a 4th dose as a booster, but not as a achieving initial immune response agent, right? What's happening is that transplant patients are just going out and doing this on their own. There have been a number of media reports about people just saying, hey, look, I need to get protected, so I'm going to go and get the doses that I need. It's interesting because those people who went and got 3rd doses before August when it was FDA approved were the ones that entered our study, gave us their blood, proved to the world that they do increase their immune response. And it was that study that motivated FDA and CDC to allow 3rd doses. So it was the brave people who were saying, look, I got to take things into my own hands, that actually generated the data to then show the FDA and CDC that this was necessary. But I think we've gotten now very complicated, right? We have 3rd doses, 4th doses, immunosuppression reduction, this and that. Like everybody needs an individualized approach. We are in a nation that is now, celebrating personalized medicine, yet this is about as impersonal as it can possibly be. And I think that that's problematic. I think we do need to put this back into the hands of the medical providers who know these patients and who can help them make these decisions.
If one of your transplant patients comes to you and wants a 4th dose, you can't recommend it?
Right now, unless, again, it's been 6 months since they had their 3rd dose, I'm not allowed to get them a 4th dose, which is very frustrating.
And I did see that some people just go out and are experimenting on themselves.
Right. I mean, they get an antibody level, they see it's low, and they sort of intuit that if they get another one, it might be higher, and then they go and just do it. And in fact, we've even had, just like we had this 3rd dose paper, we've had transplant patients go and get a 4th dose, and we've written about that in the literature, and we've shown that for some people, the 4th doses can really boost them. I mean, I can give somebody a 4th dose in our clinical trial, but outside of our clinical trial, in regular practice, we are still limited. And it's not just me, it's basically every medical provider who takes care of immunocompromised people.
So if you're just giving everybody a 4th shot, like if everybody who's immunocompromised is sort of like going out and finding themselves a 4th shot, it feels like that you're doing something over and over again and expecting a different result. But what you're saying is that it does feed on itself.
My worry is actually the people after 3 shots had enough immunity, don't know they had enough immunity, and just go and get a 4th shot because they're worried. I would really love to see this done in a data-driven manner, where we know where they stand in terms of their antibody responses. We know what immunosuppression they take. We know where, their doctors know sort of what their immune system looks like, and they make personalized decisions for people. It is true that we're sort of somewhere between, if at first you don't succeed, try again. And well, I guess the quote is something like stupidity is doing the same thing over and over again and expecting a different result, right? Like we're somewhere in between that, because we do see that for many people, every dose of the vaccine primes their immune system more. And at some point, they sort of reach that threshold and then they get over the hump and they do have a good antibody response. And, we've seen this with fourth doses for transplant patients. So, I think the research needs to progress so that we know better who would benefit from this approach, who would benefit from another approach. And we have a data-driven way of doing this, but we also, we're building the plane as we fly it. And as a result, because we're flying the plane, we need to give medical providers across the United States some control over where the plane goes for their individual patient. And right now, we don't have that.
How close do you think we are to something like that? Or are we really so concerned about, public health as a whole that we don't have space to think about these immunocompromised people?
I don't think that it's the concern of vaccine dose availability and things like that that is stifling the FDA and CDC guidelines. I think they are focused on safety. I think at this point, we know it's safe. At this point, we have so much data. And, Israel's already doing fourth doses in people and has been doing fourth doses in immunocompromised people for a long time. I think we have enough safety data to just say, look, this really needs to be individualized. We can't keep going. The CDC FDA guidelines can't be this really complex decision tree of, well, did you have 3 doses and was your antibody levels less than 250? And if it was, are you taking MMF? And if you are, then you should get a fourth dose, but it should be at 4 months, where this person should get a fourth dose at 2 months. That's just way too complicated for a big government agency to be doing. But that is what doctors do. That's like what medical providers do. They individualize care for their patient. The difference is, for any other medication I give my patient, I have the permission to do so. For vaccines, we don't have the permission to do so.
Well, Dori Segev, thank you so much for joining me.
Yeah, it's always a pleasure. Hopefully we'll have more information the next time we talk about this. And to all of my friends and dear people who are immunocompromised out there, hang in there, stay safe as much as you possibly can. And we are doing everything we can to learn more.
Public Health On Call is produced by Joshua Sharfstein, Lindsay Smith Rogers, and Stephanie Desmond. Audio production by Niall Owen McCusker, Matthew Martin, Spencer Greer, and Holly Cardinale, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media support from Grace Holz Fernandez. Thank you for listening.